Hey guys, so I wanted to go over what is ER nursing in this video. I've been having a few conversations with some of my friends. I have a few med-surg nurse friends and ICU friends and labor and delivery. So I definitely want to go over the difference and what to expect if you decide that as a new nurse that you want to do ER nursing. So the first thing I want to start off is don't listen, especially if you're a new grad, you're just graduating nursing school and you're looking for your first job. Don't listen to anyone who says that you will not get a specialty, that you have to do med surg. That is a lie. Those people have a lack of faith and lack of knowledge. There are especially nowadays with the critical need for nurses, they are so much more open to having new grad nurses in specialty departments. I know when I just started, when I graduated nursing school, there's multiple things that you also need to keep in mind. One of the main thing is be flexible about location. The specialty job that you want may not be next door. But if that's the job that you want, you should be willing to relocate. And relocate doesn't necessarily mean a different state, but it means that you could probably need to be driving 30-45 minutes. If that's a specialty you want, you need to understand sacrifice. That's the first thing. The second thing is, I remember when I was a new grad that I was told I would never get an ER job as a new nurse. And the first job I got was in the ER. The only nursing I've done is emergency nursing. So I just want to definitely put that out there. Don't let anyone discourage you because of their personal experience, especially their personal experience in the past. We are living in a new age where we are in dire need of nurses. So they're not really that picky nowadays. So with that being said, when I graduated nursing school, I applied to multiple places and I wanted to do emergency nursing first. I wanted to do either ER nursing or labor and delivery, but after doing my clinicals in labor and delivery, I wasn't really sure if I still wanted to do it because I feel like as far as pace goes, labor and delivery is a lot less dramatic as emergency nursing. So the first thing that I experienced with emergency nursing is a few things that you need to know before you can that differentiates you from other departments. One of the things is the certifications. So when I started my first job, we had what they called emergency nursing course. The first, I want to say it was 8 weeks, but I could be wrong. It was on and off. Either I was in class or I was in the hospital actually working. And it was just a little frustrating because it felt like going back to school like all over again. But at the same time, I did not complain, because you're getting paid to sit down in class and listen. So the first few weeks, one of the things that differentiates emergency nursing from other departments is the certificates that you have to receive. So I got my ACLS, my PALS. I already had CPR card. Even though the hospital that I was working in was not a trauma hospital, they actually still let me take trauma courses because every now and then we still get traumas. We're not supposed to, but we did. Because, if you're 5 minutes away and the person's about to die, you're not going to send the person to another hospital that's, 30 minutes away and decrease the chance of that person surviving. So we took an emergency course. So I had ENPC, PNCC. So think that's it. So the difference between that and other department is that in the emergency room, we take everybody. We take babies, adults, labor and delivery patients, geriatric patients, you name it, we get it. That's the difference. With med-surg, now, depending on the hospital that you're working at, it's adult med-surg. So you have to be a certain age to stay on that unit. And they will never get children because it's an adult med-surg unit. Or labor and delivery, you only get labor and delivery patients. So you only get mothers, pregnant women. So the big difference between emergency department and a lot of other specialties, the fact that you get these multiple variety of patients. One thing I can say is, if you are the type of person that you do not like specific things, being in the ER will be tough for you. There's a lot of people who hate taking care of kids, who don't like taking care of geriatric patient, and if that's the case, you shouldn't be in the hospital unless you're doing labor and delivery, you know, or pediatrics, like those specific age specific specialty. It's kind of hard if you don't like a specific kind of group. You need to think about what you want to work with. If you don't like working with kids, don't be in the ER because you're going to get kids. If you don't like dealing with pregnant women, don't be in the ER because you're going to deal with pregnant women. The good thing is, as far as keeping patients that are pregnant in the ER goes, it goes up to the weeks. So in my hospital, if they are more than 20 weeks, they go to labor and delivery. If they are 20 weeks and less, they stay in the ER, and then they would become a med-surg patient. I'm sure OB would still see them, but they wouldn't go to the labor and delivery unit. So that was the one thing that differentiates ER nursing from other is the certificates that you would need, because you're dealing with this wide variety of patients. And another thing that differentiates specifically towards those certificates, like ACLS, those means that if you have a cardiac arrest patient, you should know what to do. That's the big difference. This isn't just CPR. You need to know which meds to give, how often you can give the meds, when to hit that defibrillator. Like, that's the big difference. One of the big difference is you need to be able to know what to do in those situations, because one of the sad things with ER is we could have a mass casualty situation where we all know there aren't 30 doctors in the emergency room. At my hospital, there was only one per shift. Well, and I worked night shift, so let's be specific. On night shift, there was only one doctor, like an actual emergency room doctor. There were maybe, give or take, 1 or 2 additional nurse practitioner and physician assistant, but there was only one ER doctor. Even adding those two, say 3 providers in total, that still means in a mass casualty scenario where you have cardiac arrest over here, stroke over here, this over here, you need to be able to take charge. You need to be able to handle the situation. That's one of the biggest difference between ER nursing and other specialties, because if you're on the floor and you can call a RRT and the ICU team is going to come. You can call RRTs all you want. Somebody's going to come. But with the ER, you are the RRT. You need to handle it. Another thing with emergency room nursing is you also do psych. And let me tell you, psychiatric patients are not my thing. I don't think I have the patience for behaviors. I've dealt with angry patients all the time, but psychiatric angry patients do go to a little more extreme than I care to deal with. So I feel like there is a type of nurse for everybody. I'm not a psych nurse. So what I get, the ER always has a psychiatric unit. So that's one of the things that I just know I have to sacrifice, and I need to get over my emotions about it. The good thing is that at least my hospital, or the hospitals that I've worked in, they haven't placed one person in the psych unit 24 hours, because some people are just not psych nurses. And we never had the staff for psych nurses in the ER at the hospitals that I've worked at. So at least I know if I am placed in that unit one day, I'm not going to be placed tomorrow. That's another thing about emergency room nursing. Another difference is the medications that we give. There is so many meds that emergency room nurses give that some floors do not give. And depending on that, they might need to go even to ICU if they're on a specific drip. That's the big difference. In the ER, we are placing those patients on the drip. We are dealing with those patients on top of having other patients. So I could have a cardiac arrest in one room and still have 4 other patients. And depending on the type of hospital and the team that you're with, those patients may or may not be taken care of while you're dealing with that other patient. So, I mean, that's one of the thing about having a team that you feel comfortable with and you can trust, and you know is going to have your back in those scenarios. Because if I'm calling a code stroke or a cardiac arrest, I should not be leaving those patients to go take care of a patient with renal issues or back pain. Someone else should responsibly be taking care of those patients. But that's one of the difference between the ER nursing is the drips. We place patients on drips all the time. You need to be able to understand what needs second checkoffs, which most of the time the computer tells you that you need a dual sign off. But either way, calculating medicines, giving meds, critical meds, that's one of the difference between being on in the ER as opposed to other specialties, where a lot of those patients that are on those drips, most of those go to ICU anyways, depending on how critical it is. Another thing that is different is triage. Med-Surg and ICU and a lot of these other departments, they don't do triage. One of the main important things about emergency nursing is triaging a patient correctly, giving them the right acuity, which means that the level of care that they will demand. You don't want to put a person who is a STEMI and put them at a level 4. Logically, you wouldn't do that. So for those of you who don't know, the severity of a patient starts from 1 and it goes up to 5. 5 being the simplest thing. You came for because I don't know. A 5 would be a person, which happens all the time, who comes to the ER because they want to see if they're pregnant. So they came for a pregnancy test to the ER. That would be a level 5. A level 4 would be someone who has toothache. They just need antibiotic. A level 3 would be a level 3. And I feel like a lot of patients that come in are level 3s. So that would be my back pain. This would be my renal, like kidney stones. This would be, and then that depends, right? If this is an obstructing kidney stone where you haven't peed for days, then you're a level 2. Because now this is an emergent issue where you may or may not need surgery. You're a level 2. But if you're a kidney stone that's going to pass, you're a level 3. Level 2 would be those emergent things that they're serious, but we can handle them. We can stabilize them. A level 1 is you are like on the brink of death. Sorry, but that's the truth. You're so critical that this is like, you need to either go to, you need to go to the cath lab. You need to, I don't know, you need to go to surgery right fucking now. That's the big difference between all those different levels. So triage is very important, especially when it comes to the providers, because the providers aren't the one that are placing these acuity. The nurses are. So you need to understand where that patient is, because the doctors are trusting you to put the correct acuity on those patients, because they are going to see those patients based on the acuity. They will be in more rush to go see someone who is a level 2 than to go see someone who's a level 5. And logically, that makes more sense, right? Because if that patient needs immediate care right now, you want them to go see them so they can order the right meds, order the right exams, so those people can be taken care of right now. And then the ones that are a level 5, most of the time, those patients, the doctors don't even need to order meds. You can order meds. Well, that all depends on the hospital. But a lot of the times, triage has a lot more, those triage nurses have a lot more, what's the word? They have a lot more, I know I'm thinking the word, but I can't think the word, but they have a lot more freedom to order meds when it comes to certain things that are simple. Like if I come in for I can't breathe, you're going to order an x-ray, right? Those things. And that's what the providers expect of you, especially if you're in triage and they can't see all these patients all at once. They expect that if you're after listening to what they're saying, you can judge what they're mostly going to need. We can start that process right now. Another difference between ER nursing and some other specialty, or specialties in general, when you do specialties, there is a tendency that you get paid more because you're required to do a little bit more, technically. So I know that ER nurses get paid more than med-surg nurses. It don't necessarily mean that you're getting paid more than a labor and delivery nurse. I think also it depends on the market. It depends on the necessity at that time. So you can't really say ER nurses always get paid more. That's not always the case. The question is, which department is suffering the most at this time? That's really the truth. And sometimes it's all of them. So there is that. So I feel like for the most part, that's the difference between ER nursing and other nursing. One thing you need to know is that for the most part, the turnaround for patients is like this. It's just a new patient, new patient, new patient, new patient, new patient. So a lot of the time, if you can't go with the flow, it's going to stress you out. Like, because the truth is, especially nowadays, the hospital I'm in, there are 30 plus patients in the waiting room every damn day, every damn shift. It doesn't matter what shift you're working, 30 plus patients in the waiting room. And the problem is the ER is already at max capacity. So it's always going to be 30 plus because the patients aren't moving. One of the great things that I love the most about ER nursing is that I never have the same patient normally 2 days in a row. The only ever time, which recently that's happened a few times, is due to the fact that we don't have enough nurses upstairs. If upstairs is not upstairs as in med-surg, if med-surg is not staffed, those patients can't go up. You can't put a patient on a floor that has no nurse. You just can't do it. So every now and then, recently they've been trying really hard to move patients up, but every now and then some patients get stuck in the ER and we're holding. And God, I hate it, because I love the fact that I get a new patient every so often. If this is a true turnaround ER, then you don't really have a patient for more than, honestly, I want to say more than, give or take, 4 hours. And this is if everything gets done on time, the way it's supposed to get done on time, which includes triage, tests, results, review, bed placement, discharge. Now, if it's a discharge, that definitely could happen within 4 hours, depending on the acuity. 4s and 5s should be gone. They should not be in the ER for 16 hours. They shouldn't. But sometimes that happens, especially nowadays when we are at max capacity. There's just nothing you can do about it. But one of the things that I love is the turnarounds of patients when an ER is functioning the way it should. You get a patient, you treat them, they either get better, go home, or if they don't get better, they go upstairs. You don't keep them. New patient, if you want to learn different things, the ER is the best place for you to be. I've gotten patients, so I've had patients that were pregnant. I had a patient that had hyperemesis. She was 10 weeks pregnant, could not stop vomiting. That is not something that you would get in a med-surg floor. I had a kid, oh my God, I had this baby girl who got hit in the eye, and her cornea was cut and pupils would not dilate. She got transferred to another hospital because we don't have pediatric in the hospital that I was working at that time, but she got transferred to another hospital. But those are the things, like, you get so many different things. People with kidney stones, people with back pain. I had a woman who broke her neck and didn't even know she broke her neck. She wasn't even in a seat collar. Everyone missed the part that she fell. She never told anyone at some point she fell. Got a CT scan of her head and neck, abdomen, pelvis, and that's how we found that she broke her neck. So there's just so many things. You have patients who allergic reactions, patient who has obstructions. I had a person who was allergic to a medicine he was taking, and it completely angioedema, horribly, face swollen, neck swollen, to the point where it completely cut off his breathing, had to intubate him. We have patients that are cardiac arrest, STEMIs, respiratory distress, COVID patients, non-COVID patients, TB patients. We have, name it, we get it. That's the difference between ER. You get everything. Multiple variety of patients. If you want to learn about everything, the ER is the place for you to go. One of the downside is that a lot of patients come in for the same thing. It's like every now and then. At this one time, I had a day where I swear every single person that came in had in person, I mean men, because I've only ever experienced this with men, but urinary retention. Most likely it's because of their enlarged prostate, and they needed a 3-way catheter. That's something that a lot of departments never even get to do. And sometimes it don't even happen in the ER. It really just depends. But I have placed 3-way catheters so many times because one of the reasons was because one of the urologists at that time in that area worked in my hospital. So he told his patients to come to our hospital. So I got to do continuous bladder irrigation. Like, how many nurses have never done that? But I've done that multiple times. I've accessed ports. What else? I've accessed ports. We can do IOs. So that's putting an IV in a bone. there's just so many things that you can do with ER that it's just crazy. But I always say, I think one of the best times for me picking a specialty was clinicals. You know, if you can, what I did because in my last semester, I got the chance to pick a specialty, and I did not pick a specialty that I wanted. I picked a specialty that I never got to do during clinicals. I went to ICU during clinicals. I went to med surg, of course. We did med surg rehab. I never needed to go to the ER because I was a phlebotomist during nursing school, and the truth is I've worked every department, but I've been in the ER specifically because I was the supervisor at my hospital for phlebotomy, and one of my main thing to focus on was turnaround times for labs in the ER. So I was in the ER all the time. I was in the ER during cardiac arrest, during during so many traumas. So I knew what to expect as far as workload, because I had friends that were ER nurses, and I was working in the ER, not doing nursing, but definitely witnessing all the work that the nurses had to do. So I didn't need to do clinicals in the ER. I did clinicals in a psychiatric unit. See, that's what I'm telling you. Take the opportunity to do all of them so you can really see which one you want or you don't want to do. Psychiatric unit, I did clinicals in peds, and I did clinicals, and I chose to do clinicals in the NICU because that's not a department that you really get to go visit and actually work in. And I feel like for the most part, working in the NICU was interesting, but it was too sad for me. I definitely, babies, I can't do babies, sick babies. It's really sad. So definitely take the opportunity to see everything, try everything before you pick a department, and don't be closed-minded to it, because not because you start a department means that you have to stay in it. You can switch. Remember, it's your life that you have to live with it. So if you're not happy, change. If you're not happy, change. Because I feel like one of the biggest thing for me when I became a travel nurse is that I was only a nurse for 1 year. And I listened to so many people who were like, oh, Chantal, you need at least 2 years. Or, oh, you should at least get a little bit more experience before you do this, because I've heard X, Y, and Z. But here I am also placed in a charge position. You're giving me 6, 7 patients at a time, and I'm doing my job, and I'm still doing my job better than people who have 4 patients. So why the hell am I limiting myself to this hospital? Because the truth is, you're telling me all these things, not because for my benefit, but you're telling me these things because you don't want me to leave your hospital. Which is great for me. That speaks highly of me. But no, I know my worth. Take a job that A, you're happy with, and B, that you're getting paid correctly for. Travel nursing, like, it just blows my mind how everyone is in travel nurses. And it also blows my mind how people don't realize you could do local travel nursing. That means you live in Baltimore, you work in Baltimore. You live in Pennsylvania, you work in Pennsylvania. And guess what? You're still getting paid more than all those nurses. You don't get the stipend, but you get $95 per hour. When I started as an emergency nurse, I only got $31 an hour. Even if I kept that job and worked as a travel nurse, I would still get more money. So like I said, know your worth. Don't limit yourself. Don't let other people limit you, because they don't know. They're just saying it because out of their own fear. So that's it for this video. Leave a comment. Don't forget to subscribe, and I will see you in the next video. I definitely want to do a budgeting video and a review video for the meals because, oh, I love them. But I wanted to actually open up a meal, show a video of it so you guys see what it looks like and everything, and haven't gotten a chance to do that. So that video is coming up. But I'll see you guys in the next one.